what is normal and what is abnormal. So my first talk here is basically about the normal variants of growth in children, which are great mimickers of other conditions, which you can mistake and diagnose wrongly. There are three parts to this lecture. The first part is variants of normal facial growth. Now the proximal humerus and the scapula develop from a number of ossification centers beginning with the glenoid, which ossifies before birth. This is followed by the appearance of ossification centers in the coracoid in the first few months of life. An additional center of ossification is seen at the inferior tip of the scapula during adolescence, and the acromion is formed again from multiple ossification centers and which coalesce by the age of 22 years. All these centers may demonstrate varying degrees of mineralization and should not be confused for fractures. The elbow ossification centers we all know of. The capitulum comes about 1 year, radial head about 3 years, medial epicondyle about 5 years, trochlea 7 years, olecranon 9 years, and the lateral epicondyle by about 11 years. And this mnemonic called CRE-TO is something we need to remember and not mistake it for an injury. The radial physis near skeletal maturity may have a small spur on the distal aspect of the radius and should not be confused for a fracture. Sometimes there is an irregular ossification of the pisiform which is confused for a fracture, especially if your views are not taken correctly, and an MRI can help you differentiate this problem. A false scapholunate widening can probably be because the lateral pole or the inferior pole of the proximal pole of the scaphoid, it ossifies a little later as compared to the distal pole, and this interval can sometimes be taken up as an injury to the hand, and an MRI will help you differentiate it. Ischiopubal synchondrosis is seen in smaller children, but usually if these children are, their age is on the higher side, and if it is a unilateral thing, it can sometimes be confused as an injury. Sometimes irregular ossification center of the proximal femoral condyle, which is common in almost 34% of boys and 11% of girls less than about 12 years of age, can sometimes be mistaken for some sort of an injury. An irregular ossific nucleus of the anterior patella at times can also be mistaken for an injury. Biparietate and triparietate patellae, which basically occur because of failure of fusion at times, but is common in about 2% of the population, can also be sometimes mistaken for an injury. There is something called as a dorsal defect in the patella, which is a well-defined radiolucent area with a sclerotic margin. Again present in 1% of the population, etiology is unknown, but it is probably thought of because of area of the failed ossification of the epiphysis, can sometimes be mistaken for an injury. So do the ossification center of the tarsal bones, which may be multiple, especially the navicular, and sometimes it can be mistaken for some sort of an infection, and the absence of clinical symptoms and signs tell us that this is not a Kohler's disease, but a ossific problem. Sometimes the base of the fifth metatarsal apophysis can appear like a fracture, but you need to remember that this is essentially an oblique radiological appearance in contrast to fractures, which are usually transverse. The second part of this lecture is the appearance of tendinous and ligamentous insertions, which can sometimes look like injuries, infections, or tumors. The clavicle, the contour of the clavicle may appear irregular at times at sites of ligamentous attachments. A depression termed as the rhomboid fossa is often present along the inferior surface of the clavicle on the medial side at the site of attachment of the costoclavicular ligament, and this rhomboid fossa may vary in size, may be irregular, and may be mistaken for a lytic lesion. The coracoclavicular ligament, which is composed of the trapezoid and the conoid ligaments, extends from the inferior surface of the clavicle to the coracoid process. Sometimes a bony prominence known as the conoid tubercle or conoid tuberosity may be seen at the attachment of the site of the coracoclavicular ligament along the inferior aspect of the distal clavicle, and an articulation at times is present between the conoid tubercle and the coracoid process, and this may be mistaken for a benign tumor. The insertion of the latissimus dorsi, which is basically sometimes appears as a focal cortical irregularity at the site of attachment in asymptomatic patients, many a times the MRI can also show an increased uptake or some sort of a marrow change, but that is normal if there is no clinical symptom. Deltoid tuberosity thickening at times can be mistaken for some sort of a growth or some sort of a benign tumor, and one needs to know this anatomical landmark when one is looking at the X-rays. Sometimes the bicipital tuberosity can have a lucency there which may appear as a pseudo-lucent lesion, and this needs to be confirmed before you label it as any sort of a pathology. The third part of this lecture is the miscellaneous conditions, like something called as the distal femoral avulsive cortical irregularity. It is a focal excavation of the posterior medial cortex of the distal femur metaphysis and can occur at the insertion of the medial gastrocnemius muscle tendon in asymptomatic patients. Though it is referred to as a cortical desmoid, it should not be considered as a pathological lesion because this is a totally benign entity and actually it is an attachment. Sometimes you can have overlapping lines like undulated physeal plates is very commonly seen in the developing skeleton, and the margin of the physes are usually smooth and slightly sclerotic, differentiating them from fractures. Sometimes overlapping bones can also be considered or can be mistaken for fractures, and these may pose a diagnostic dilemma in both the developing and mature skeleton. These lucencies may sometimes be seen through the metatarsal bases on certain radiographic projections due to overlap of adjacent metatarsal bones. Vascular channels are lucencies within bones which course obliquely throughout the cortices of the bones. They may be confused with fractures in both children and adults. However, vascular channels are not as sharply defined as fracture lines. Vascular channels appear as small round lucencies when seen. Something like a tilted sternum, which is a rare thing but an obliquely oriented sternum with a rib convexity, can sometimes be taken as some sort of a congenital anomaly, and hence one has to be very particular when one examines and tries to see this normal anatomy from a congenital anomaly. Physiological varus and valgus of the lower limbs can sometimes be mistaken for pathological conditions. Pathological genu varum is something which persists beyond 3 years of age, and pathological genu valgum is something which persists beyond 7 years of age. Physiological genu varum is greatest between 1.5 to 2 years and should spontaneously resolve ideally by 3 years, and genu valgum is something which is common up to 3 to 4 years and should ideally resolve at about 7 years. So to conclude my talk for today, variants in the pediatric musculoskeletal development are common and can often lead to diagnostic confusion on imaging studies. Familiarity with imaging appearances of common variants is important for radiologists as well as orthopedic surgeons for allowing a confident identification of these findings as normal patterns of development. Thank you.